Shall we start then? We start. So, Srijit, where are you? Srijit?
Okay, madam.
Okay, we'll start.
Okay, start. Madam, please unmute. Madam, unmute.
Am I audible?
Yes, very much audible.
So good evening, dear members. Welcome to a new month, February. And this time we have a really good topic awaiting us. That is MISC, a review by Dr. Shiji Joseph, followed by Approach to Arthritis, a case-based approach by Dr. Harikrishnan, who is a rheumatologist, both of them from Amla Medical College. Our last month was really jam-packed with activities. We observed two very important days, Girl Child Day and Leprosy Day, World Leprosy Day, National Girl Child Day, and World Leprosy Day. We held two talks with national speakers, one on COVID vaccines, the other collaborating with the Pediatric Orthopedic Society of India. And we celebrated Republic Day with real patriotic fervor. Not forgetting to take care of personal health with so many of us members counting our steps even now for the ongoing walking competition. So 3 cheers for our branch. Day after tomorrow, many of our members will be participating for the World Cancer Day programs, and our next Zoom activity will be on the 9th. Don't forget to attend. And do you know who the speaker is? She's the first PG who passed out from Thrissur Medical College, Dr. Badira, who will address us on an oncology subject. And we also will be having a PG teaching program by the Government Medical College PG, and this time in the subject of cardiology. So welcome friends, let us start the program, and the first one is MISC, and I will introduce Dr. Shiji, who is our first speaker. Dr. Shiji Joseph, she's managing the pediatric rheumatology clinic at Amla. She did her MBBS from Government Medical College, Kozhikode. I remember last time Dr. Riaz was singing a lot of praises about you, Dr. Shiji. She did her MD Pediatrics and DCH from Government Medical College, Kozhikode, and completed the EULR course in Pediatric Rheumatology in June 2020. She is the Assistant Professor of Pediatrics and doing in charge of the Pediatric Rheumatology Clinic at the Amla Institute of Medical Science, Thrissur. Over to you, Shiji, for the talk.
Thank you, madam, for the kind words. Madam, am I audible?
Much audible.
Thank you, madam. Thank you. Good evening, all. Respected teachers, senior members of the forum, and my dear friends. At the outset, let me thank the IAP Thrissur office bearers and all its honorable members for giving me this wonderful opportunity to discuss on a topic of great current relevance today. We started getting reports of a hyperinflammatory syndrome in children, which was later labeled as multisystem inflammatory syndrome in children associated with COVID-19 from April 2020 onwards. Many of us might have already had an encounter with MISC, but some might not. Before entering into the topic's details, let us first come in terms with the clinical presentations of MISC through one of our patients. Okay. Okay. MISC can very well be called as a masquerader. It's a clinical masquerader with its varied presentations. So we had a 12-year-old girl in the early days of November 2020. She was referred as a case of meningitis. She presented with fever of 4 days duration and headache, vomiting and loose stools of 3 to 4 days duration, and an erythematous rash over the body and dizziness of 2 days duration. She had no history suggestive of COVID-19, but there was history of URI affecting many family members in the last 1 month, and her grandfather had pneumonia 2 weeks ago, but he was tested COVID negative. On examination, the child was sick-looking and drowsy. She was in shock. She had poor peripheral perfusion. Her BP was only 70 over 40 millimeters of mercury, and she was obese. She weighed 65 kg. There was conjunctival congestion, but there was no oral mucosal changes. Palms and soles were erythematous and swollen. There were erythematous maculopapular rash all over the trunk and medial aspect of the thigh, as you can see in this picture. An eschar was not seen. Systemic examination was essentially normal, except for a right hypochondrial tenderness. The differential diagnoses which were considered at that point of time were dengue shock syndrome, rickettsial disease, and also septic shock was also considered. And in view of the news from far and wide that MISC is also on the rise in our part of the world, we considered MISC in shock also as a differential diagnosis. Investigations from outside revealed a neutrophilic leukocytosis, high ESR and CRP with deranged renal function. Her COVID RT-PCR was negative. Investigations from our lab revealed almost the same results. There was neutrophilic leukocytosis, ESR was 80, and there was renal urea was 44 and 1.3 creatinine, hyponatremia, hypoalbuminemia, and other inflammatory parameters all were high. CRP was high, ferritin, D-dimer, and also procalcitonin was also very much elevated. Her troponin I and BNP was also found to be high. SARS-CoV-2 antibody came positive. So, and her chest X-ray showed cardiomegaly with bilateral non-homogeneous opacities. USG abdomen was normal, essentially normal. Her ECG showed sinus tachycardia with prolonged PR interval, suggestive of first-degree heart block. And her echo showed mitral regurgitation and tricuspid regurgitation, suggestive of valvulitis, as you can see in this video. And there was also movement abnormalities of inferior wall, suggestive of myocarditis. Coronaries were essentially normal and texture, in size and texture. So what is the diagnosis? So we made the diagnosis of multi-system inflammatory syndrome in children associated with COVID-19, that too severe illness. So let us move on to the topic proper. In the early part of the pandemic, children infected with COVID-19 were thought to be highly resilient and were having mild symptoms. But from April 2020 onwards, reports from UK and all over the world came about a new hyperinflammatory disease temporarily associated with COVID-19 infection. This phenomenon was later on labeled as multisystem inflammatory syndrome in children, or MISC, or pediatric inflammatory syndrome, multisystem syndrome temporarily associated with SARS-CoV-2, or PIMS-TS. MISC is a rare complication of COVID-19 in children with excellent outcomes when treated appropriately. Incidence is 2 per 1 lakh, and Black and Hispanic children are found to be affected more than Asian children. It is seemed to be affecting healthy children, especially of older age group. They are found to be symptomatic after about 3 to 4 weeks of COVID-19 infection. And the important comorbidities associated with MISC are obesity and bronchial asthma. Regarding the pathophysiology, in both children and adults is not well understood, but a dysregulated immune response is thought to be the culprit. It can be a T-cell recognition of self-antigens, otherwise known as molecular mimicry, resulting in autoantibody generation, or antibody or T-cell recognition of viral antigens expressed on infected T-cells and hyperimmune response, or a viral superantigens which activate host immune cells via an unconventional mechanism. All these are thought to be the propagating events. So what is the case definition of MISC? WHO and CDC has defined the case MISC with little subtle variations. That is, WHO definition includes 6 principal elements. That is, pediatric age of less than 19 years, persistence of fever more than or equal to 3 days, presence of laboratory markers of inflammation, signs or symptoms of multi-organ dysfunction, and there should not be an alternative diagnosis and a temporal relation to COVID-19 infection or exposure. CDC definition is also says almost the same criteria, but they have shortened it into 4 criteria: age less than 21 years, clinical presentation consistent with MISC, no alternative plausible diagnosis, and recent or current SARS-CoV-2 infection or exposure. We'll go into clinical definition of CDC clinical definition in a little more detail. Age should be less than 21 years. There should be fever and laboratory evidence of inflammation, including but not limited to any of the following: elevated CRP, ESR, fibrinogen, procalcitonin. Any of these can be elevated, and there can be lymphocytopenia and hypoalbuminemia, and out of which any should be there. And among multi-system involvement, there should be 2 or more organ systems involved: cardiovascular system in the form of shock, elevated troponin, elevated BNP, abnormal echocardiogram, arrhythmia, etc. Respiratory involvement, pneumonia, ARDS, pulmonary embolism, all can be there. Then renal, there can be acute kidney injury. There can be neurologic involvement in the form of seizures, stroke or aseptic meningitis, hematologic involvement as in the form of coagulopathy, gastrointestinal involvement in the form of abdominal pain, vomiting, diarrhea, etc., and also dermatologic manifestations. Any 2 of these systemic involvement should be there to consider a diagnosis of MISC, and it should be a severe illness requiring hospitalization. There should be no alternative plausible diagnosis, and there should be evidence for recent or current SARS-CoV-2 infection or exposure in the form of positive SARS-CoV-2 RT-PCR, positive serology, positive antigen test, or a COVID-19 exposure within the last 4 weeks prior to the onset of symptoms. These points highlighted in this screen, these were all the findings that we got in our patient, that index case that we saw initially. So there is an entity called multisystem inflammatory syndrome in adults also described, which requires 5 criteria: a severe illness requiring hospitalization as in children, in a patient aged more than 21 years, a positive test result for current or previous SARS-CoV-2 infection, severe dysfunction of 1 or more extrapulmonary organ systems, laboratory evidence of severe inflammation in the absence of severe respiratory illness. So these are the defining criteria to make a diagnosis of MIS-A. Coming to the clinical features of MIS-C, the major clinical features include: presenting symptoms include persistent fevers, gastrointestinal symptoms like diarrhea, abdominal pain and vomiting, rash, conjunctivitis, which is non-purulent, mucous membrane involvement, neurocognitive symptoms, and respiratory symptoms. The majority of the patients will present with fever, gastrointestinal symptoms, rash, and conjunctivitis, etc. Coming to the clinical findings, there will be shock. Majority of the patients will have shock. There will be features of Kawasaki disease, which can be typical or atypical Kawasaki disease. There will be features of myocardial dysfunction, clinically or echo-wise. ECG may show arrhythmias in the form of 1st or 2nd degree heart block or even 3rd degree heart block. Then acute respiratory failure, acute kidney injury, features of serositis, hepatitis, encephalopathy, all can be there. These are the clinical findings that we can expect. So this was one of our other patient that he had MISC showing oral erythema, non-purulent conjunctivitis, and we can also see erythematous maculopapular rash. Coming to the laboratory findings, there will be abnormal blood cell counts in the form of neutrophilia, lymphocytopenia, mild anemia, and thrombocytopenia. Platelet count can be normal or low. And inflammatory markers will be very much elevated, including CRP, ESR, D-dimer, ferritin, procalcitonin, interleukin-6, fibrinogen, etc. There will be elevated cardiac markers like troponin and BNP. You can have hypoalbuminemia, mildly elevated liver enzymes, elevated LDH, CPK, and CPK. Continue laboratory findings. ECG will show arrhythmias, as we have already mentioned, heart blocks, ectopics, etc. And echocardiogram will show depressed LV function, coronary artery abnormalities, valvular abnormalities like mitral regurgitation or tricuspid regurgitation, pericardial effusion also can be there. X-ray and CT will show pleural effusion, patchy consolidations or atelectasis. USG abdomen may show ascites, bowel and mesenteric inflammation. COVID RT-PCR and SARS-CoV-2 serology will be may or may not. RT-PCR may or may not be positive. There can be positive serology also. And we also need to send a complete metabolic panel, including RFT, LFT, serum electrolyte, blood urea creatinine, that is RFT, and also serum calcium and glucose. And testing for other pathogens, which includes blood culture, urine culture, and serology for leptospirosis, rickettsial infections, EBV, dengue, whichever is indicated, depending on the differential diagnosis that we consider, should also be sent. Now, coming to the clinical spectrum of COVID-19 and associated MISC. Illnesses associated with COVID-19 can be divided into those associated with active COVID-19 and those with MISC. COVID-19 children can have mild disease or severe illness. Mild symptom means no or mild symptoms, and in severe cases, patient will be having respiratory failure, neurologic symptoms, coagulopathy, shock, or patient will be in cytokine storm. A patient with MISC can have a febrile inflammatory state. He can be having KD-like illness, or he can be a case of severe MISC. In febrile inflammatory state, patient will be having mild symptoms. There will be persistent fevers and elevated inflammatory markers, lacking signs of severe multisystem involvement. In MISC, KD-like illness, they will meet the criteria for complete or incomplete KD, do not develop shock or severe multisystem involvement. And in severe MISC, markedly elevated inflammatory markers will be there, severe multisystem involvement will be there, and cardiac involvement and shock are common. Let's see how we will differentiate between Kawasaki disease and MISC. In MISC, KD-like illness, the children can be older children and also adolescents, but we get usually infants and young children with Kawasaki disease, not related to SARS-CoV-2 infection. And GI symptoms, neurological symptoms, and myocardial dysfunction and shock are more commonly associated with MISC, whereas it is less commonly associated with Kawasaki disease, not related to SARS-CoV-2 infection. Inflammatory markers will be very high in MISC, whereas in KD, it will be elevated. There can be lymphopenia in MISC, but lymphocytosis can be there in KD. Platelet count elevation is less common in MISC, but elevated platelet count is a hallmark of Kawasaki disease. Coronary artery abnormalities are still being estimated in MISC, and we all know that KD is associated with 25% risk of coronary artery abnormalities when left untreated. So, when should you suspect MISC as a part of your differential diagnosis? Persistent fever without a clear clinical source is the first clue. And you have to ask about epidemiological or look for epidemiological link to SARS-CoV-2 infection in the past 4 weeks in any patient who is presenting to you with significant fever and associated symptoms. There should be any two of the following, among rash, gastrointestinal symptoms, edema of hands or feet, conjunctivitis, lymphadenopathy, and neurological symptoms. Any two of the following should be there. And in any child in whom you suspect MISC, they should also be evaluated for other infectious and non-infectious etiologies. Let us see how to proceed further when you have got a patient in whom you suspect MISC. This is an algorithm or diagnostic pathway developed by American College of Rheumatology. So when you have a patient suspected to have MISC, as we have already discussed. Fever, epidemiological link, and any two of these clinical findings. You have to try and rule out other plausible causes. If you have already ruled out these causes, consider this child under investigation for MISC. Then the next question comes, does the child have shock of unclear etiology? If the answer is no, you can start tiered diagnostic evaluation for MISC. Start tier 1 screening evaluation, including complete hemogram, complete metabolic panel, which includes RFT, LFT, seroelectrolyte, calcium, glucose, etc. Then ESR, CRP, SARS-CoV-2 PCR, and or serologies. And if the results comes like this, there is elevated CRP, ESR more than, or ESR, high ESR, CRP, elevated CRP or high ESR in the presence of at least one suggestive laboratory feature like this. Absolute lymphocyte count less than 1000, platelet count less than 1.5 lakh per microliter, hyponatremia, neutrophilia, and hypoalbuminemia. Any one among these two in the presence of high CRP or ESR, you can go on to the tier 2 or complete evaluation for MISC, which includes, as we have already discussed, other tests, which are BNP, troponin T, procalcitonin, ferritin, PT, APTT, D-dimer, fibrinogen if available, then LDH, cytokine panel if available, then triglycerides and SARS-CoV-2 serology. Peripheral smear, ECG, echo, all are warranted at this point of time. Again, if the patient in question had shock of unclear etiology, you can complete the full diagnostic evaluation, tier 1 and tier 2, then and there itself. And if the patient, initially the patient had fever, there is epidemiological link, but no features, any clinical feature suggestive of MISC, you can continue diagnostic evaluation as per standard of care and monitor for MISC features, particularly if there is an epidemiological link to SARS-CoV-2 infection. Now, whom will you admit? Hospital admission is indicated in all children in whom you suspect MISC with abnormal vital signs, that is tachycardia, tachypnea, then respiratory distress. Then any patient with neurological deficits or change in mental status, including subtle manifestations, you can consider hospital admission. Evidence of even mild renal or hepatic injury, and markedly elevated inflammatory markers, high CRP or ESR, and abnormal ECG, high BNP or troponin T. In all these patients, you should consider hospital admission. Outpatient evaluation is indicated or warranted only in those well-appearing children with stable vital signs and reassuring physical examinations, provided close clinical follow-up can be assured. Coming to the management, MISC is managed by a multidisciplinary team, including a pediatrician, cardiologist, intensivist, pediatric rheumatologist, hematologist, and whichever specialty is indicated as per the patient's clinical features. And supportive, and it should be managed under, all these should be taken care of: supportive care and correction of shock, immunomodulatory treatment, cardiac management, and antiplatelet and anticoagulation therapy. These are all part of management of MISC. Supportive care include a good intensive care with correction of shock and respiratory support. Inotropes should be selected depending on cardiac contractility, pulse pressure, and other dynamic features. Empiric antibiotic can be started in the presence of, especially when there is fever and critical illness. And choice of antibiotic may be modified depending on local antibiogram, patient characteristics, and the suspected differential diagnosis. Coming to the immunomodulatory therapy, a patient who is hospitalized with MISC, ask whether the patient has shock or organ-threatening disease. If the answer is yes, your first-line treatment will be IVIG, that is 2 gram per kg, and methylprednisolone, low to moderate dose methylprednisolone, 1 to 2 mg per kg per day. And if the patient is having a refractory disease is one in which the patient is having fever after 2 days or 36 to 48 hours of first-line treatment, and within any time within 1 to 2 weeks of first-line treatment. Okay, so in that case, you can intensify the treatment with methylprednisolone, that is pulsed high-dose methylprednisolone and or high-dose anakinra. Unfortunately, anakinra is not available in our country. And if the child is not in shock and there is no severe organ-threatening disease, again, the first-line treatment is IVIG only, 2 gram per kg. And if the treatment fails or if the patient is refractory to IVIG therapy, you can go on to give intensification of treatment with methylprednisolone, IV 1 to 2 mg per kg, that is low to moderate dose methylprednisolone, and so on. A few words on IVIG. Again, first aid therapy in MISC. Dose is 2 gram per kg based on ideal body weight, administered as a single dose infusion over 8 to 12 hours. And in case of severe LV dysfunction, it can be given over 2 to 3 days because for fear of fluid overload and cardiac dysfunction. In case of refractory MISC, a second dose of IVIG is not recommended. That is again because of fear of volume overload and hemolytic anemia associated with large doses of IVIG. Regarding glucocorticoids, it can be used as an adjunctive therapy in patients with severe disease or as an intensification therapy in refractory disease. We have already seen low to moderate dose glucocorticoids, that is 1 to 2 mg per kg per day of methylprednisolone for 5 days and then taper over 2 to 3 weeks. That is the dose to be given, is given in a patient as an adjunctive therapy who is having severe disease, who is in shock and organ-threatening disease, and with those with milder forms of MISC who are refractory to a single dose of IVIG. High-dose IV pulse glucocorticoids is recommended in refractory MISC who are having severe illness and if child requires multiple inotropes or vasopressors. Coming to anti-Plateau therapy, that is aspirin. A low-dose aspirin is indicated in all patients with MISC and it is contraindicated if there is active bleeding, significant bleeding risk, and or platelet count is less than 80,000 per microliter. Aspirin therapy, low-dose aspirin therapy should be continued until normalization of platelet count, and this coronary arteries should be documented to be normal, having the normal caliber at more than or equal to 4 weeks after diagnosis. Coming to therapeutic anticoagulation, which is also an important part of management of MISC. With enoxaparin, the indications include documented thrombosis, a patient with cardiac involvement with ejection fraction less than 35%, if there is coronary artery aneurysms and a maximal Z-score of more than or equal to 10. These are the indications for starting enoxaparin. Indications for longer outpatient therapy with enoxaparin include coronary artery aneurysms or abnormalities with Z-score more than 10, in which case you need to give indefinite treatment. Documented thrombosis, that is, treatment should be considered for more than or equal to 3 months pending thrombus resolution. Ongoing moderate to severe LV dysfunction is also an indication for longer outpatient enoxaparin. Coming to the cardiac management of MISC, any patient with MISC and severe cardiac involvement may present to you with arrhythmia or hemodynamic compromise. So in these patients, if there is abnormal BNP or troponin T at diagnosis, they should be repeated over time until they normalize. And serial ECGs and echocardiograms, depending on the severity of cardiac involvement, should be a guide to your management. And if there is conduction abnormalities are present, the patient should be placed on a continuous telemetry while in hospital, and Holter monitors should be considered during follow-up if the arrhythmias or conduction abnormalities persist. Regarding the follow-up, we'll be discussing later. And a few words on hyperinflammation in COVID-19. COVID-19 can be complicated with hyperinflammation. Those patients who are at high risk include those children with underlying medical conditions and those on immunosuppressive medications. And I'll be just focusing on immunomodulatory treatment in children with COVID-19 and hyperinflammation. Indication for immunomodulatory treatment in children with COVID-19 and hyperinflammation include those children with severe respiratory symptoms and with any of the following: acute respiratory distress syndrome, shock or cardiac dysfunction, substantially elevated inflammatory markers, and or depressed lymphocyte count, low albumin, and or platelet count. So any of the following with severe respiratory symptoms in a patient with COVID-19 can be considered for immunomodulatory treatment. The drug of choice is glucocorticoids again. The second line treatment recommended is anakinra. As we have already seen, anakinra is not available in our country. Other immunomodulatory agents like tocilizumab and infliximab, etc., can be considered depending on the clinical situation of the patient. So, coming to the follow-up of a patient with MISC, we should be aware about the sequelae of MISC. There can be coronary artery abnormalities, myocardial fibrosis or scarring, and conduction abnormalities, especially if a patient had cardiac involvement with acute MISC. So, echocardiograms should be repeated at 7 to 14 days and at 4 to 6 weeks after presentation. And in children with cardiac involvement in the acute phase, an echocardiogram should be repeated after 1 year or depending on the clinical situation of the patient. Cardiac MRI is also recommended in patients with MISC 2 to 6 months after diagnosis, especially when there is significant transient LV dysfunction in the acute phase of the illness. That is, LV ejection fraction if it was less than 50%, or there is persistent LV dysfunction. Cardiac MRI may show you about myocardium, if there is fibrosis or scarring. And cardiac CT is indicated if there is suspicion of distal coronary artery aneurysms that are not well seen on echo. And we should make a decision regarding stopping low-dose aspirin and or enoxaparin if it is there. All these are based on the presence or absence of coronary artery abnormalities and LV dysfunction. So, I would like to give you a post-test after having seen a patient in the initial phase. That was one of our first patients. And after treating and discharging that patient, after 2 weeks of her discharge, we got another boy, another masquerader, came with a 13-year-old boy, referred as a case of food poisoning. He presented with fever of 7 days duration, vomiting 6 days, and loose stools of 5 days and excessive tiredness of 1 day. On examination, there was tachypnea, tachycardia, low BP, there was conjunctival congestion, and oral mucosal changes. Investigation showed neutrophilic leukocytosis, elevated inflammatory markers, positive SARS-CoV-2 serology, and abnormal echo. So, what is the diagnosis? That is my question to the audience. If you are able to make a diagnosis at this point of time, I'm happy and satisfied that this presentation was of some use to us. So coming to the take-home message, it's a new disease. We need to be aware and vigilant, and we should be aware of the clinical phenotypes, especially a child with fever and shock. A child can present you with atypical KD. A child can present you with acute abdomen. He may be taken up for even exploratory laparotomy and other masqueraders, as we have some of them that we have seen, meningitis or food poisoning. All these are clinical phenotypes in which shape these patients may present to you. Relevant and timely investigations will help you make a prompt diagnosis, and early immunomodulatory therapy and supportive therapy is a must for an uneven full recovery. And be aware about the sequelae like coronary artery abnormalities, myocardial fibrosis or scarring, and conduction abnormalities. And follow-up of these patients with MISC is a must. And we were fortunate to have our first patient for her first review on the day of inauguration of our pediatric rheumatology clinic at Amala on 2nd December 2020. And she was doing well at that point of time. And we were happy to have her as one of our guests. Thank you. Thank you all for the patient listening. Thank you, IAP Thrissur, and all its honorable members.
Thank you, Shiji. That was an excellent presentation. We shall have the discussion later after the second talk. At this juncture, I would like to welcome, I can see many senior members here, Purushothaman sir, our state leader, Johnny Sebastian sir, Komlavali madam, Parvati madam, Saroja madam, Muralidharan sir, Verma, Dr. Verma, Dr. Lakshmanan, Dr. Jose Goodwill, and anybody else whom I have missed out. At this juncture, Dr. Purushothaman sir, I remember last week you had given a very nice YouTube presentation. Sir, would you like to give your comment now on this case?
Dr. I think discussion will keep at the end after Hari's talk, I think.
Oh, okay, sir. Thank you, sir. So the next topic is by Dr. Harikrishnan, who will be talking on approach to arthritis, a case-based discussion. A short introduction on Dr. Harikrishnan. I'm very happy to say he has done his MBBS from Government Medical College, Thrissur, following which he did his MD Pediatrics at Chandigarh and DM Rheumatology at the King George Medical University, Lucknow. He has done his MRCP in Rheumatology and is a member of the Royal College of Physician. He has done his fellowship in Rheumatology from UK. Over to Dr. Harikrishnan.
Thank you, ma'am. Thank you for the wonderful introduction. Am I audible?
You are, but a bit louder would be better, I think.
Okay. Thank you for the kind introduction. I'm really honored to speak in front of my beloved teachers and respected senior members of IAP Thrissur. I wholeheartedly thank IAP Thrissur for giving this opportunity. So without wasting time, I'll be going into the presentation. So when an arthritis patient walked into the floor, I wanted to walk out the back one. Sir William Osler. This was the situation when I finished my MBBS and when I joined my MD Pediatrics at PGH and DL. So going straight to the topic. So what is arthritis? We all know arthritis is definition of arthritis.
കുറച്ചുകൂടി ബാൻഡ് വിഡ്ത്ത് കിട്ടും എനിക്ക് തോന്നുന്നു ശബ്ദം ക്ലാരിറ്റി വരുന്നില്ല.
Okay, sir. So can you hear right now?
Yes, better, much better.
Okay. Arthritis definition is basically swelling or effusion of a joint or any two of the other following. That is the limitation of joint movement, pain on movement, or heat or warmth overlying the joint. This is the classic definition from the Cassidy et al. And this is the criteria for classification of juvenile idiopathic arthritis, age less than 16, arthritis, duration more than 6 weeks duration, and onset depending upon number of joints, poly, oligo, or systemic disease. So just going into a basics of joint anatomy. So we can see that there is bone. Just above the bone there is a capsule, and inside the capsule there is a synovium. And just outside the capsule, we have other structures called ligaments, tendons, muscles, bursa, and these all structures can get involved in arthritis, and it can present as joint. So coming to the physical examination of the child with musculoskeletal problem, it should be a child-friendly approach. Importance should be given to assess the general health status, anthropometry, important, keeping the developmental norms in mind, and you need to do a complete medical examination, and all joints should be examined even if the complaints are referred to only one. Coming to PGALS, what is PGALS? It's basically a evidence-based screening musculoskeletal tool for school-age children, which has got excellent sensitivity and specificity, ranging approximately 97 to 100%. And this is based on adult GALS, gait, arm, leg, and spine screen. And the importance is that we can complete it in 2 minutes, less than 2 minutes. So this is the PGALS screen. So looking into the arms, making a fist, opposing the thumb, pinching the thumb with the index finger, squeezing the wrist, making this wrist in position, these positions, shoulder movements. In legs, examining for the knee joint. This is examining for the hip joint. Again, hip rotation. For spine, we can see the spine movement, examining from the back and seeing the lumbar spine movements and examination of temporomandibular joint. Following PGALS examination, we need to go to the individual joint examination, inspection for swelling, redness, and position of the limb, palpation for any warmth, local rise of temperature or tenderness. We need to assess the range of movements, both active and passive. Certain conditions involve both active and passive joint involvement, especially the inflammatory arthritis. Both active and passive joint will be involved. But certain conditions involving the extra-articular tissues, only the active joint will be involved, and some passive may not be involved. And you should assess the presence of fluid by patellar tap. So the question coming is whether this condition is acute or chronic. So what is the relevance? So an arbitrary cutoff of 6 weeks is taken to differentiate between acute and chronic arthritis. So those presenting acute less than 6 weeks and more than 6 weeks. So the more than 6 weeks, most probably it will be juvenile idiopathic arthritis, slow growing infections like tuberculosis, fungal infections, brucella, and rare disorders. Coming to acute disorders, so it can, if it is happening over hours, then it can be bacterial arthritis, post-trauma, coagulopathies. If it is developing over days, it can be infections, viral, post-viral, bacterial, rheumatic fever, connective tissue disorders, vasculitis. This can be the etiology. And obviously, concept of juvenile idiopathic arthritis. So next question is whether this condition is articular or periarticular. Again, we need to see the joint anatomy over here. So this is the joint capsule, and inside the capsule is articular, and just outside the capsule is extra-articular. So the extra-articular manifestations of involvement include bursitis, tendinopathies, muscle pains, and enthesial pains. The enthesial sites are the sites where the muscle attaches to the bone through a tendon. So how to differentiate between articular and periarticular? So the anatomical structures involved in articular conditions is synovium, cartilage, and capsule, whereas as I said, it is tendon, bursa, ligament, muscle, bone can be involved in periarticular pain. The articular pain is usually diffuse, deep, and it will be having pain in both active and passive movements and in all planes, because you can see this capsule is involved in each angle, in each range of movement. When you move, there will be pain. However, in the periarticular pain, there will be a focal pain. Suppose if someone has a bursitis, only the bursal area will be having pain, and it will be active only. And in case of an enthesitis, those muscle movement, the causing stretch of the tendon or muscle will cause pain. So the pain will be limited into few planes or few movements. Swelling is common with articular conditions like effusions or joint capsule swelling. However, periarticular, like enthesitis, bursitis, there will be only mild swelling or less swelling. So we need to consider whether the question is again inflammatory or non-inflammatory condition. So the inflammatory conditions, how can we differentiate inflammatory with non-inflammatory? The inflammatory conditions, the pain occurs in the morning hours. There can be articular or soft tissue swelling. Erythema, the features of inflammation, calor, dolor, rubor will be present. Erythema, warmth, morning stiffness will be present. And in some cases, systemic features can be present. Inflammatory markers, ESR, CRP will be elevated. Synovial fluid, if you do a synovial fluid aspiration, total leukocyte count will be more. Examples include septic arthritis, other inflammatory arthritis. As coming to the non-inflammatory part, the pain will be more during evening hours, because after the stretch and the work, the pain increases and it improves after rest. Again, the inflammatory pain, because of the cytokine accumulation after rest, the cytokines accumulate in the tissues, which results in pain in the morning. Again, swelling will be absent. Erythema, warmth, other features of inflammation is usually absent. Systemic features are absent in non-inflammatory conditions. ESR, CRP are less elevated or not elevated. WBC count, synovial fluid is less. The classic conditions is avascular necrosis or SCFE. So the question is whether someone has a child having joint pain, whether he has got morning stiffness, gelling, that is the morning stiffness, worsening symptoms with cold weather. Yes. If it is yes, it is suggestive of arthritis, spondyloarthropathy group, or inflammatory rheumatology conditions. If there is no morning stiffness and the pain is only during night, or it is not joint centered, especially around the joint in the muscle, it's an intermittent symptoms and there is no daytime complaints, it could be suggestive of growing pains. Again, if there are systemic symptoms present, fever, weight loss, and fatigue, you should always consider the diagnosis of malignancy in background. And if there is any constant pain, should consider the diagnosis of osteonecrosis, avascular necrosis, or amplified pain syndrome. If the pain is again intermittent, not much interfering with this with the daily activities, and it increases after activity, and then we need to consider about the syndromes causing pain after overactivity, which includes various skeletal variations, pes planus, knee deformities, scoliosis, and everything. Number of joints involved. So if it is oligoarticular or polyarticular. So polyarticular involves more than or equal to 5 joints, and oligoarticular involves less than or equal to 4 joints. And is there any involved joint? Is there any is the involved joint characteristic of a particular disorder? Yes. In psoriatic arthritis, distal interphalangeal joints are especially involved, especially if they have got nail involvement, because the nail plate originates from the just below the DAP joint. So that if someone is having DAP arthritis, there should be usually there will be nail involvement. In bilateral temporomandibular joint involvement in RF negative polyarticular JA, and there is a preponderance of lower limb joint involvement in reactive arthritis and enthesitis related arthritis, because they are the weight bearing joints. Sequence of joint involvement. So we need to take a meticulous history asking for the pattern of joint involvement, whether it is an additive, which happens with the normal inflammatory arthritis, juvenile idiopathic arthritis, connective tissue disorders, whether it is migratory, which is classically seen in rheumatic fever, some viral infections, Lyme's disease, or intermittent or palindromic onset. So this is a bit confusing among physicians, so that the palindromic arthritis, they consider it as migratory arthritis and do the workup for rheumatic fever and other things. So intermittent arthritis subsiding by itself, it could be the onset of a generalized systemic arthritis, juvenile arthritis, or a systemic disease causing arthritis. So it could be the onset, and later it can change the pattern. Whether any deformity is associated. So joint deformities indicate a long-standing aggressive disease, and certain diseases like lupus, inflammatory bowel disease, Parkinson's disease in adults, they can have non-deforming arthritis. Is there any limb length discrepancy? So the limb length discrepancy is characteristically seen in oligoarticular JA. So those are arthritis starting before the age of 9. If there is inflammation in the joint, there is a stimulation of the epiphyseal cartilage, which results in the lengthening of the affected joint. Ultimately, it will result, because of the inflammation, there happens a premature closure of the epiphysis, which results in shortening of legs. Other extra-articular features. Is there any enthesitis? Enthesitis is the inflammation of attachment. You can see these are the sites of enthesitis. These are the sites where the bone, the tendons get attached to the bone. And the most common site of enthesitis is calcaneus, tibial tuberosity, metatarsal heads, ischial tuberosity, patella, and iliac crest. So basically, these are all predominantly, the enthesitis are predominantly in the lower limb or in the weight-bearing region. So the stress or stretch, that is the shear force, is the predominant factor causing enthesitis. We need to see for other extra-articular features like dactylitis. Here in the X-ray, we can see that in the photo, you can see that there is a swelling of the second toe, and in the X-ray also showing the swelling. You should look for other features like uveitis. Here you can see the features of uveitis, and rarely hypopyon uveitis can happen. Features of ulcerative colitis. involving causing anemia, bleeding in stools, and many of the inflammatory arthritis, especially the enthesitis related arthritis, the adult, the juvenile counterpart of ankylosing spondylitis, can have overt IBD or subclinical IBD, which can result in anemia and other features of inflammatory bowel disease. Again, next question: systemic involvement. Are there any extra-articular features, or is there the extra-articular features dominate the clinical picture? Whether there is any skin involvement suggestive of malar rash, any other rash suggestive of Henoch-Schönlein purpura, IgA vasculitis, any systemic involvement like gangrene, which can be suggestive of connective tissue disorders or vasculitis. Patient profile is the age of presentation or gender specific. We all know that certain diseases like connective tissue disorders have got a female preponderance, SLE 3:1 up to 9:1, and and for juvenile idiopathic arthritis, there is definitely a preponderance for the various subtypes. And is there any significant family history also? So the most important thing in identifying or classifying juvenile arthritis is pattern recognition. So the clusters of features elicited above, does this can we make out a recognizable disease pattern out of this thing? So I'll be going to cases directly. So case 1. This is a 6-year-old boy presenting to the OPD with 24-hour history of fever and swelling of left knee. He is in severe pain, resting to wear weight. He has no significant past medical history. His immunizations are up to date. Examination revealing red hot knee with severe limitation of movement. So the answer is obvious. It is septic arthritis. Red hot knee, monoarthritis. We will have to rule out septic arthritis in any monoarthritis presenting with red hot knee, especially in a childhood. In adults, there can be other differentials like crystal arthritis, but again, in children, a red hot knee, single joint involvement is always septic arthritis. It is a medical emergency. We need to act fast. So I'm not going much in detail to theory. So bacterial invasion of the synovial joint space. Most common organism is Staphylococcus aureus. MRSA gonococcus should be kept in mind because the antibiotic choice is different. For neonates, group B Streptococcus, E. coli should be considered. In sickle cell, Salmonella need to be considered. Most common spread is hematogenous spread. Contiguous spread from soft tissue or bone can happen. Most common affected joint is knee in children, and in infants it is hip. It is a true clinical emergency. As long as the pus accumulates and pus remains there, it will erode the cartilage very fast, and we need to drain the pus as early as possible. The most consistent sign is pain with passive motion, which children will not be moving the legs, or there will be positive movement, and the joint will be kept in a position with the maximum intracapsular volume. For example, in the hip, it is abducted and externally rotated. And apart from that, child will be sick, toxic appearance, and other features of sepsis. So joint aspiration is mandatory. We need to put a needle as fast as we can do and start empirical antibiotics. Intravenous antibiotics should be started after sending cultures, and we need to modify the antibiotic as per the sensitivity. And total recommended dose course is 6 weeks. Case 2, a 3-year-old child refuses to walk. She had a upper respiratory tract infection a week ago. She is afebrile. Apart from the right hip pain, examination revealing right hip pain, she is active, playful, but she is not walking. Counts, inflammatory markers are all normal. So this is a case of transient synovitis of it. So usually seen in young children, toddlers, 3-4-year children, and up to 8 years. Sudden onset pain or limb usually happens in hip, unilateral. Most of the children may have a history of upper respiratory infection. So the important thing is that this is a diagnosis of exclusion. We need to consider always septic arthritis in these children, and we need to rule out septic arthritis. If you have got any doubt, always try to put a needle in and to try to aspirate. Transient synovitis of hip is a self-limiting condition. We need to give analgesia and rest that will improve over time. So it's not a dangerous thing, but behind it, we should be aware about the septic arthritis thing. Case 3. So a 5-year boy who has been unwell for past 20 days in form of having fever and unilateral pain of ankle joint. At presentation, he's having difficulty to bear weight in that leg, and he has got inability to sleep. That is very important due to excruciating pain. Examination revealing sternal tenderness, hepatosplenomegaly, inflammatory markers yes are elevated, platelets are low, peripheral smear showing lymphocytes. So we all know the diagnosis. It is leukemia or malignancy, acute leukemia. So we should so malignancy, the possibility of malignancy should be considered even in the absence of other clinical features like pallor, lymphadenopathy, hepatosplenomegaly. When I was doing DM in second year, we had a difficult case. This child presented with features of systemic onset JA. He had a 5 or 6 year old boy. He had typical features of lymphadenopathy, polyarthritis, and high fever, elevated ferritin, elevated inflammatory markers. We were again suspicious. We did bone marrow. Bone marrow was not showing any malignancy. We started him with steroids. As soon as we started tapering steroids, he again appeared to have arthritis and fever. And then he developed hepatosplenomegaly. Subsequently, we had to do a repeat bone marrow, and the repeat bone marrow showed blast. So even bone marrow examination can also trouble us. If the initial bone marrow is not showing the result, then we can also get confused. Case 4. 8-year-old female child presented with pain in the legs, mainly in the evenings for the last 1 year. So duration of last 1 year, so chronic thing. Pain is mostly in the legs, involving occasionally upper limbs also. Pain, at times the pain is severe, making her cry, and she finds it difficult to fall asleep. And the pain is get relieved by massage. She was quite normal throughout the day, able to do all the strenuous physical activities. No other worsening symptoms, past history, family history. All the investigations are normal. So this is a case of hypermobility. So hypermobility children can present with pain. Usually the lower limb joints are involved, rarely upper limb also. Usually the pain happens in the evening or night, which gets relieved by massage. So we can see the hypermobile joints in this case. The Baton score, it will be coming in subsequent slides. So the hypermobility children can present with pain, predominantly lower limb, more common in girls, and it decreases with age. They can also have concomitant fibromyalgia. The important thing is to consider other heritable disorders of connective tissue disorders like Ehlers-Danlos, and we need to examine for increased skin laxity and other features, the eye features and everything. Basically, it requires only supportive care, reassurance, physiotherapy, and to muscle strengthen the muscles so that the child, the effort or the brunt on the joint is taken care. And counseling to activities like gymnastics or activities which cause joint capsule to stretch excessively. NSAID should be used for pain relief. So this is the Baton's criteria. See, we can see that the patient can touch the floor with the arms. She can take the arms back and make a prayer sign behind the shoulder, behind the back. Her knees are hyperextended. She can she can sit on abnormal postures. See the thumb can be flexed to the forearm, and other features. The elasticity of the skin is increased. The Baton scores, it has got four components: the spine, the thumb, the small little finger, knee, as well as elbow. Pointed 1 point for each, and if there is a score more than 4 or above, we can consider hypermobility. So these are common findings which comes in OPD. So when I was in UK, in the pediatric rheumatology clinic, the most common case coming to a pediatric rheumatology case was benign hypermobility, and the GPs were afraid and they were referring these cases to us. Coming to the next case, this is a 4-year-old boy. He complains of history of left knee swelling and pain, which happened over last few days. Examination revealing swollen and tender knee. So our first diagnosis is septic arthritis. We need to rule out septic arthritis again, but ESR-CRP is not elevated. So in order to do a rule out septic arthritis, joint aspiration is done. It is showing blood. So blood investigation showing prolonged APTT. On reviewing the history, the maternal uncle had similar illness. Factor levels were sent. It is proven case of hemophilia. The same this exact case happened in my second year posting, second year training, DM training in Lucknow. I had a child. I referred for sent for joint aspiration, and the OPG called me, told it is blood is coming. So these are all surprises. And case number 6, a 4-year-old girl walking into the OPD with a limp and does not bear weight on left lower limb. History, swelling of left knee with pain for last 2 months. There is no, again, monoarthritis, single joint, but no fever, no weight loss. Child is active, playful, non-sick. Examination showing left knee swollen and minimal tenderness. Rest of the joints are normal. So only one joint is swollen, no danger signs, no red herrings. ESR-CRP is normal. Again, we need to rule out tuberculosis because it's a monoarthritis, long-standing. Mando chest X-ray normal. Diagnosis is oligoarticular JAA. So it's one of the common subvariants of JAA. Most commonly happens in children, in preschool children, girls predominantly, present with a limp, or the mother usually notices the child is limping or while bathing. Upper limb involvement is less common. Wrist involvement is not common. And it is again divided into persistent oligoarticular, which the joint involvement persists for less than or equal to 4 joints during the first 6 months. And if it is going more, then it is an extended oligoarticular, which has a worse prognosis. Most important thing in oligoarticular JA is to screen for asymptomatic uveitis. So in this oligoarticular JA, uveitis is asymptomatic. Children are young age, 3 or 4 year girls. They won't be able to tell symptoms, and moreover, this is asymptomatic. So this asymptomatic uveitis can cause vision loss on later life. So these are the highest risk young girls, oligoarticular JAA, ANA positivity. So in this variant of JAA, we need to screen every child of oligoarticular JAA for uveitis and to do ANA. And we need to do regular eye screening as per the protocols. Coming to case 7. This is a straightforward case. 12-year-old girl, history of additive arthritis involving small joints of the hand and feet, later involving large joints for last 6 months, occasional intermittent low fever, and over the time the deformities are developing and contractures are developing, subcutaneous nodules present. So we can see that there is a deforming polyarthritis involving multiple joints. There are multiple nodules over the knuckles as well as over the spine. So this is a characteristic case of polyarticular JAA. Polyarticular JAA, more than 5 joint involvement. It can be of 2 variants, rheumatoid factor negative and rheumatoid factor positive. So these two behaves completely, there is a significant difference between the presentation and prognosis. Obviously, RF positive polyarticular JAA has a poorer prognosis, and RF negative has a better prognosis. RF negative presents, it has a bimodal distribution between 2 to 4 years and then 6 to 12 years. Females more. In the negative variant, RF negative variant, the number of joints are less, more asymmetrical presentation, and most importantly, TMJ and cervical spine may be involved. This is very important. The prognosis is better than RF positive polyarticular JAA, but it is a chronic disease. It requires monitoring and disease modifying treatment. and this is likely to go on to continue into early 30s and 40s. So this is a counterpart of seronegative rheumatoid arthritis in the adults. Then the RF positive polyarticular JA, this resembles the seropositive rheumatoid arthritis, presents in the adolescent age group around 12-13 girls. This usually goes into adult as rheumatoid arthritis, deformities, both large and small joints can be affected, symmetric arthritis, involving MCP-PIP, and it can involve other extraarticular manifestations, lung involvement can happen. And the characteristic deformities in rheumatoid arthritis like Butner deformities, Van deformity can happen. Prognosis, it has got poor prognosis. Without treatment, remission is very chance of remission is very little. Even with treatment, the disease is difficult to manage, and in significant percentage of children develop deformities. So the poor prognostic factors are hip involvement, hand involvement, and wrist involvement. Case number 8. So a 4-year-old boy presenting into pediatric rheumatology clinic with high spiking fever and well circumscribed evanescent salmon pink color rash presenting on the trunk and extremities for 15 days. Examination revealed lymphadenopathy, hepatosplenomegaly, chest X-ray showing cardiomegaly and minimal pericardial effusion. Blood investigation showing elevated total leukocyte count with polypredominant and platelets are high, 5.6 lakhs with elevated ferritin. So this is a case of systemic onset juvenile idiopathic arthritis. So we can see the characteristic fever pattern. So in this, the fever pattern, the fever starts from the baseline from 37, touches 40, come down to baseline. Again touches the 40, come down to baseline. So this is a characteristic quotidian fever. The rash, hepatosplenomegaly and lymphadenopathy, and we can see the Koebner phenomenon that happening in the rash, those areas of trauma, the rash happening in the areas of trauma. So it can present as it can initially present with fever and then joint arthritis, or it can present with joint pain and then subsequently fever. So important thing is that it can involve cervical spine and wrist involvement, and it can cause deforming arthritis in wrist. And one of the dreaded complications of this thing, this systemic onset juvenile idiopathic arthritis, is macrophage activation. You can see in this picture, the macrophages are eating RBCs. So when will we suspect macrophage activation? So when the pattern of fever, initially it was a quotidian fever touching the baseline. So the pattern changes to continuous fever, unremitting fever, then bruising, purpura. These are all features of cytopenia, like low platelets, low hemoglobin, then enlarged lymph nodes, liver, spleen, hepatosplenomegaly due to consumption of blood cells, liver dysfunction, CNS involvement including seizures, multiple organ failure. The lab features which can help or predict is the fall in ESR. If a child having systemic onset JA which is an active JA, and he develops a fall in ESR and total leukocyte count and platelet count, we should be worried. We should be strongly thinking about developing macrophage activation and to do the workup. So it shows elevated ferritin, transaminase, elevated triglycerides, and fall in fibrinogen. So the fall in ESR is because the fibrinogen get consumed. So the because of the fibrinogen falls, the ESR falls. So this gives a false hope, but the fever become persistent fever, but the ESR goes down. Coming to the next case, this is a 9-year-old boy presenting with asymmetric arthritis involving large joints of lower limb. Similar, another boy presenting with monoarthritis of left joint and low back pain. On examination, marked tenderness of the patella and right SA joint is tender. So this is enthesitis related arthritis. He has got features of asymmetric arthritis and features of localized tenderness of in patella, that is enthesitis involving tendons around patella and SI joint tender. This is the adult. This is the in the adults. The spondyloarthropathy group, ankylosing spondylitis group of disorder is the counterpart. So this is a HLA beta 7 positive arthritis, enthesitis related arthritis. So predominantly involves the lower limb, asymmetric involvement, hip, SI joints, and these children can progress to ankylosing spondylitis as the time passes. So, but in contrast with adults usually the symptoms, the arthritis starts from the SI joint and ascends upwards. So the inflammation begins at SI and goes up. But in children, it can have peripheral arthritis first, and axial involvement may not happen or can happen later. So these are the enthesial points around knee, the Achilles insertion, as well as the sole of the foot and the plantar fascia. The Schauber's test, modified Schauber's test for measuring the lumbar spine mobility, 10 centimeter above and 5 centimeter below the line traversing the posterior superior iliac spine. If the measurement when after the child is told to flex completely, if the increase is less than 5 centimeter, it is suggestive of modified positive modified Schauber's. Prognosis, as compared to adults, the prognosis is better, but again we have to work. We have to keep in follow up for development and progression to adult juvenile ankylosing spondylitis. Hip disease is a poor prognostic factor. We have to keep always watching for hip disease to happen. So case 10, 5-year-old girl presenting to OPD with right knee arthritis, monoarthritis for last 3 months. So the infection part is ruled out, less likely. She has on examination, she has also got the IAP joint involvement. On family history, father is being treated at dermatology department with topical skin creams and sunlight therapy. So the diagnosis is psoriatic arthritis, juvenile psoriatic arthritis. So the characteristic nail changes, onycholysis, splitting, and in this photo you can see the dactylitis happening in the middle finger. Dactylitis can do, and the characteristic nail changes. Two types of presentation can happen in juvenile psoriatic arthritis. Young girl presenting with lower limb arthritis, oligoarthritis, asymmetric arthritis. In that case, ANA can be positive. They can have uveitis. So these children usually have dactylitis or involvement of the ANA. The other presentation is an old boy presenting with lower limb arthritis, asymmetric oligoarthritis. Here it can progress to spondyloarthritis. Case 11. So this is an interesting child. This was in fact my first case when I joined DM in Lucknow. So this is a 12-year-old boy, resident of Lucknow. He presented with right-sided hip pain for 3 years and difficulty in walking for 1 year. There is no history of other joint pain or other systemic signs. Examination revealed a waddling gait and the hip movements were painful. The inflammatory markers were normal: ESR, CRP, rheumatoid factor, anti-CCP, ANA, all negative. So our residents, my seniors, were actually stuck with the workup of this patient. And as soon as I joined, because I was a pediatrician, they gave the case to me. So this was his photograph. So on seeing his face, I was suspicious about some dysmorphic features. He has got a wide intercandal distance, some prognathism, coarse facies, and the abdomen was protuberant. The ribs were having some rickets-like changes. There was pectus carinatum. So there was the scoliosis is not obvious in the photo, but there is a scoliosis. In the lateral view, there is a characteristic beaking deformity in the lumbar and thoracic spine, and the ribs were sort of flat, ribbon-shaped ribs. So probably we all know the diagnosis by now. And the hip X-ray was showing both hip joints were damaged. At that time, his mother came to visit, and his mother had a characteristic eye finding. She had a corneal opacity. Despite taking history, no one was mentioning about the corneal opacity. But when the mother came, the diagnosis was clear. It was we suspected mucopolysaccharidosis type 4, We sent to Sanjay Gandhi PGI for genetics department for evaluation. They did prove by enzyme analysis, and subsequently he's under their follow-up. Again, another boy, 8-year-old boy, complaints of swelling and pain in bilateral knee and ankle, elbow, with joint flexion deformity in fingers of hand. There was no history of fever or any other features of inflammatory arthritis. Repeated history told the younger sibling also had similar complaints. So apart from the joint swellings and the camptodactyly, rest of the system examination was normal. Inflammatory markers were normal. These are the photos of his knee. The hand showing the camptodactyly. Then the X-ray of the hip showing acetabular cyst. So this is camptodactyly arthropathy Coxa-Vara syndrome, CACP syndrome. This can be confused with JAA. The important thing is that it lacks the signs of clinical inflammation, either biochemically or in biopsy also, normal inflammatory markers. X-rays can show acetabular cyst in pelvis, and a differentiating or a subtle feature is that cervical spine usually is not getting involved. So this is in a completely non-inflammatory condition. We can give only supportive care, physiotherapy, pain relief, and there is no requirement for immunosuppression. There is no benefit in doing immunosuppression. So just summarize, this is the ILA classification of juvenile idiopathic arthritis. Various categories: systemic oligo-JA, polyarthritis, RF positive, RF negative, psoriatic arthritis, enthesitis, colitis arthritis, undifferentiated arthritis. Not going in detail, we all know this is a table from Nelson. So the main features of the subtypes of juvenile idiopathic arthritis. So most of the these groups have a characteristic age group, male is to female ratio, and special features. The pattern of the arthritis can differ. Extra-articular features definitely will differ. Oligoarthritis, RF negative polyarthritis can have uveitis, and this can be asymptomatic uveitis. In systemic JAA, the fever, rash, the serositis, it can go for macrophage activation. The RF positive one, it presents with rheumatoid. It can present with rheumatoid nodules, aggressive course. The long-term remission is unlikely. Psoriatic arthritis, enthesitis arthritis, it can have its presentation, the characteristic enthesitis, dactylitis, uveitis, and everything. But in this enthesitis-related arthritis, the uveitis is usually anterior uveitis and usually symptomatic, in contrast to the asymptomatic uveitis in oligoarthritis. Management evaluation includes hemogram, inflammatory markers, liver function, renal function test, normal test. Special radiographs basically to rule out other conditions like infections, malignancies, other infections and other this thing. And in chronic arthritis, we can see evidence of bone damage and erosions and extraarticular osteopenia. X-rays can see, it can also reveal the soft tissue swelling, enthesitis, dactylitis, the dactylitis and changes of enthesitis. Here the X-ray showing premature maturation and the number of carpal bones are increased. Ultrasound and Doppler, newer modalities can detect the blood flow in the joints and see the hyperemia, soft tissue hyperemia and synovial hyperemia. Now it has become gradually it is coming up, ultrasound and Doppler is coming up in musculoskeletal system. MRI can show, will give better idea about the damage of cartilage, bone marrow edema and other changes, effusions and other changes. It's a contrast enhanced image showing effusion, is a big effusion, and the synovial is enhancing. The drawbacks, it's a cost effect, it's expensive and the time required sedations and other issues. So there are red herrings, the possible red herrings. So in a oligo-JAA, if it is presenting in a male more than 4 years, sick-looking child, significant systemic signs, isolated hip involvement, features of dactylitis, elevated ESR or rheumatoid factor positivity. These things, if these things are present, you need to look for alternate diagnosis or keep your diagnosis in suspicion. Again, in polyarticular JAA, if it's a male in a younger age group, because it's not the characteristic age group. Polyarticular JA comes in females, in adolescent females, just like rheumatoid. Other systemic features, isolated single joint involvement or large joint involvement. These are the these are the red herrings. In systemic JA, always it's a great mimicker for, we always get confused with acute leukemia or other malignancies. So it should be kept in mind. So summarizing. So a young girl presenting with a lower limb arthritis involving few joints, oligoarticular JA, ANA should be done. Screening done should be done for asymptomatic uveitis. Another case, older boy, lower limb arthritis, fewer joints, HLA B27 related arthritis, enthesitis related arthritis. It can have acute symptomatic uveitis. Adolescent girl, multiple small large joints, deforming arthritis, that is RF positive polyarthritis. It's a poor prognosis, need to keep in strict follow-up. Any age, high grade fever, rash, systemic onset JA, which is a diagnosis of exclusion. So basically the pattern recognition, associated systemic features, extraarticular manifestations, these all guide the diagnosis. So these are my take home messages. So all joint pains are not due to arthritis. There are a lot of mimickers. JA itself is a heterogeneous phenotype, and each subvariant can have has variable prognosis. Most important thing is pattern recognition and specific, and based upon the specific complications and targeted investigations and management. Thank you. I thank all the office bearers of IAP Thrissur for this opportunity. It's a great honor to present in front of my teachers, my MBBS teachers. I can see most of them here. Thank you all.
Thank you, Dr. Harikrishnan, for the very lucid discussion on arthritis. I invite Dr. Purushothaman, sir, for comments.
Thank you, Hari, Shiji. Both of them did very well. I see Somasegara Pilla sir in the audience. Most of you may not be knowing Somasegara Pilla sir and relation with Hari. Hari, son-in-law of Somasegara Pilla sir. He was our HOD earlier, and many senior members. My comment about Shiji's presentation, definitely it was a very good presentation. And about the MISC, our experience in all over Kerala, it's not that older age group. It's a little bit on the lower side compared to the Europeans, and it may be emerging on to the more likely we are confusing the typical Kawasaki also. And of course, our management is maybe over the coming years and months, a lot of modification may come, because you are yet to know what all pictures actually represents and what will the ideal management, what all complications are likely to happen. We don't know it's equal to Kawasaki. At present, we all think that is same as Kawasaki. It may not be. The involvement of the coronary, involvement of the myocardium, all these things may be different. And the choice of the drug also. About the steroid and IVIG, we are more and more depending on steroid rather than IVIG, especially in a little bit older child. We are more and more depending now on steroids, both in Calicut and Trivandrum also. They are reserving IVIG for very sick children, younger children, bit of older person. We are more in using steroid. And one important message to the pediatricians, hereafter, we are all very likely to overdiagnose and a little bit of underdiagnosis. Overdiagnosis is also possible, and maybe you are likely to miss treatable entities like ricket cells, like dengue. A lot of other treatable entities may be missed. So at present, if you're in doubt, and many of the sick children, better to give a cocktail of the ricket cell, ceftriaxone, and the staph cover, and with the steroid also, and maybe reconsider this thing, because you can't afford to miss a child if it is especially sick child. The other way also is possible. wrong diagnosis of the situation. Missing of the MISC situation also is possible. So it was a good presentation, Shiji. Then about Hari, you presented 13 case scenarios, and almost all the senior persons, Dr. Bharati Madam, Kamalavalli Madam, Dr. Murli, everybody will think why you didn't mention about rheumatic fever, because at that time we are all thinking Hari will be presenting at least one case of rheumatic fever amidst all these things. So that is what has happened over the time, because that was the era when we all consider rheumatic as the first, and JIA rheumatoid arthritis on only rarer. All the other arthritis we occasionally only made the diagnosis. Now it's the reverse. You're considering all the other rare entities, and rheumatic is going out. But of late, we are getting a little bit of a more number of rheumatic fevers coming back again. And about the tuberculosis also, we are getting a typical presentation of tuberculosis now. You showed the dactylitis and all. We had a few cases of tuberculosis presenting in with an atypical presentation. About the malignancy, just like you mentioned, we also had bad experiences with the malignancy, especially AML cases are the one which are cheating. Even the peripheral smear bone marrow first diagnosis, first bone marrow showing negative, and later after steroid it will come. We had experience like that. So thank you both of you for teaching us, coming again, teaching for the senior citizens. We are going back, and you come with newer and newer knowledge. Thank you both of you.
Thank you so much, sir, for the kind words and the beautiful advice also. Thank you, sir.
Now the forum is open. Any senior members in the academy can open the comments. Parvati Madam is also there. Invite for comments.
Hello. Can you hear me?
Yes, ma'am.
Both of them, both Shiji and Harikrishnan, both of them presented very well. Excellent presentations. Congratulations. And MISC, usually they say, I have no personal experience, but MISC, usually myocardial involvement is more than in KD, where you get coronary involvement.
Yes, ma'am.
Is it so? Purushothaman?
Yes.
Maybe, madam, in the last week I was participating in another discussion where maybe our experience with monitoring the coronary, we may be missing a coronary involvement in both in Thrissur and Calicut experience. At Trivandrum, they are getting more of coronary involvement also. Maybe because in-house pediatric cardiologists, they are looking, the aneurysm part may be not there, but the other early evidences of coronary involvement, they may be picking up and we may be missing. But as Madam said, almost all the cases we had a myocardial dysfunction invariably. The coronary involvement were less in Thrissur case and Calicut also. So we should be more vigilant on the coronary involvement also. But the definitely the aneurysm
and
the
regarding arthritis, Harikrishnan, he hasn't mentioned rheumatic fever at all.
Yes, ma'am. Actually, ma'am, in my career, like during my training period, I have seen a few cases of rheumatic fever in Thrissur Medical College when I was doing my MBBS. Subsequently, during my MD days, I have seen a couple of cases only, and subsequently during the DM and over the years, I am not seeing that much cases. So probably that might have caused me not to pick up, not to bring it up here. Sorry for this thing.
Okay, but recently we have few cases, I think. During last few years, we are getting cases rheumatic fever again.
Okay.
Okay, thank you very much. Okay,
Thank you. Muralidharan sir, any comments, sir?
One question to Shiji.
Yes, sir.
Presently, we have a patient of MISC.
Yes, sir.
And child is improving without any treatment. In that case, all the parameters, CRP has come down, ESR has come down, fever has come down. And in that case, should we go for a treatment at all, or can we wait?
Sir, as we all know, it's an evolving entity, but we are always equating it with Kawasaki disease only. And with regard to Kawasaki disease, even if the fever has come down, if the ESR and CRP are elevated, we go for treatment only. We go for treatment. And in this case, if the patient's ESR, CRP, everything is coming down, and the probability of having a coronary artery aneurysm cannot be ruled out in a later date. On a later date. So at least we may have to put him on low dose aspirin if all the parameters are normal, and look for coronary artery abnormalities also.
Okay, Shiji. Congratulations. Very good presentation.
Thank you, sir.
Okay, we have a few questions in the chat box, and one is to Dr. Harikrishnan. And the question is about the role of bone marrow examination in MAS. And do you have to wait for this bone marrow to start treatment? And what is the imperative for the diagnosis?
Preferably, bone marrow is we should be doing bone marrow, but we should not wait for the bone marrow result to come. So what we do is we just take the bone marrow, ask the pathologist to see the smear, even if there is no to see for any evidence of HLH in the smear and any features of HLH, and just after the bone marrow we start giving pulse steroids. So giving a single dose of pulse steroid may not cause much harm. So you don't have to wait for the report of bone marrow to come. But doing bone marrow is definitely required because it will clinch the diagnosis.
Okay, thank you. Another question is actually asking about a word about DMRD, disease-modifying drugs, and how will you counsel a patient before starting methotrexate?
So usually children tolerate methotrexate very well. The most common side effects associated with methotrexate, which we see in adult counterparts, is nausea, vomiting, elevated transaminitis. These all side effects are very rare in children, and usually children tolerate well. And because the adults have a component of fatty liver, they have the transaminitis and all these things. So children usually doesn't have the the fatty liver, so they are usually protected. So what we counsel regarding the routine hygiene, to measures to be taken to prevent infections, and just routine things.
What are the usual DMRDs you're using for children, usual in your practice?
So we are using almost same DMRs as the adults, like conventional synthetic DMRs, including methotrexate, sulfasalazine, hydroxychloroquine, leflunomide, and in biologic DMRs, including anti-TNFs, rituximab. These things are all, we are using all biologics and anti-TNF medications.
In adolescent girls, if you give methotrexate, sterility is a problem, is it not?
No, sterility actually, if someone is about to get married, I usually counsel them regarding the teratogenicity. But the teratogenicity, we need to tell them not to get pregnant for during the course of methotrexate, and to inform us and to get it stopped for at least 3 months before planning pregnancy. But it will not reduce the ovarian reserve.
Okay, there is one.
Can I mention?
Yes.
Recently, there was a forward from Dr. Suma Balan about methotrexate being prescribed, and some general pediatrician passing a comment saying that it is not necessary. Have you come across that forward? Dr. Narayanan has forwarded it.
No.
Srijit.
Yes. Dr. Harikrishnan, your comments about that?
So it's always a problem.
No, I think the methotrexate was not used for the rheumatoid arthritis. It was for some other condition.
Yes,
repeated one.
Yes.
What is that? Osteomyelitis. Some sort of
yes.
That is what she said. And the consultant pediatrician probably did not know. that this was an indication. Actually, what he should have done was, he or she should have done was, ring up Dr. Suma and then ask her why this was started in the first place. That was not done. Whenever a general pediatrician sees a patient like that, started on a drug for which he doesn't know the indication, the best thing is bring up the person concerned and then ask what is to be done. Is it the right thing? Then the answer is there always. I think without asking that, we are not supposed to do that. That is what I feel.
Okay, thank you, sir. So I think we have finished all the questions from the chat box, and I thank the speakers. We have already answered.
One thing I wanted to ask Shiji, what is in the American criteria, the age group has extended to 21 years. Now, why they have put the children MISC up to 21 years?
For that, I'm not sure. Maybe they were initially seeing patients up to 21 years and later on only MIS-A was identified. It is seen in even more older age group.
Interesting. Okay.
Just one comment. Dr. Murli's question is pertinent because we need to tailor the medications in the coming months. And actually, there are few cases where you may be confused. The inflammatory markers are high clinically, but what should be the ideal treatment? And there are few people giving low dose steroids a few days in that situation also. We don't know what will be the outcome. And we are likely to face the scenario somewhere around June, July. Why? Because now the kids and the senior citizens are comparatively protected, we are keeping. And we are counting the number of positivity, mortality, morbidity daily. But maybe by the end of February, March, the cases number will be coming down and the monitoring part will be going down. And maybe the next March second half, we'll be starting the vaccination of the senior citizens. So by June, July, we'll be finishing the senior citizens also. And the screening will go down. Schools will open. And 80% or 85% of the kids will be asymptomatic. So very likely that without our notice, the kids will be positive and nobody will be knowing that whether this is being circulated among the kids. And at that time, we'll be getting more and more of these atypical presentations. Even now, the spectrum of the problems are yet to know. So it's not equivalent to the Kawasaki. It's not equivalent to what we see or reported from the European countries. Our own kids may be reacting differently and our own scenario may be different. And we are yet to get more number of atypical cases somewhere in the second half of the 2021. By that time, at least you should be aware what is the ideal dosage and this thing. Because in a resource poor scenario, if the number of inflammatory syndromes are much high, we may not be able to give IVIG and that type of management at that time. Thank you.
Lizzie madam, before we closing, any more comments, madam? So,
I think as Parvati madam was saying, it is the chronic recurrent multifocal osteomyelitis. Harikrishnan, that was the disease for which methotrexate was started. Chronic recurrent multifocal osteomyelitis.
Yes.
Varmaji, എനിക്കൊരു ചെറിയൊരു പോയിന്റ് എൻ്റെ കൂടെ ആഡ് ചെയ്യണ്ടേ ബിക്കോസ് നമ്മൾ അങ്ങനെ ഒരു 3000 ജനറൽ പീഡിയാട്രീഷ്യൻസിനെ ഒരു ബ്ലെയിം ചെയ്യുന്ന രീതിയിൽ ഒരു സൂപ്പർ കൺസൾട്ടന്റ് ആയിട്ടുള്ള ഒരാൾ എഴുതുമ്പോഴും അല്ലെങ്കിൽ പറയുമ്പോഴും that should be does not be crossing the limits of decency. അത് അതിൻ്റെ അകത്തുള്ളൊരു കാര്യമുണ്ട്. രണ്ടാമത്തെ ഒരു കാര്യം, when you are writing a drug, it should be explained very well to the person so that ആ പേഴ്സണ് ഒരിക്കലും മറ്റാൾ പറഞ്ഞുകൊണ്ട് മാത്രം ഡോക്ടർ സ്റ്റോപ്പ് ചെയ്യാൻ പാടില്ല. അപ്പോൾ 3000 പീഡിയാട്രീഷ്യൻസ് തെറ്റാണെന്നും ഞാനൊരു കൺസൾട്ടന്റ് സൂപ്പറായിട്ട് പറയുന്നതാണ് ശരി എന്നുള്ള വാദം ശരിയല്ല. there is something to be blamed on somebody's side also. Better explain. ആ ഒരു കാര്യം ആരാണെങ്കിലും ഉണ്ട്. അതും കൂടി കൺസിഡർ ചെയ്യേണ്ടതുണ്ട്. ഞാൻ 3000 പെഡിയാട്രീഷ്യൻസിനെയും കൂടി വേണ്ടിയിട്ടാണ് ഞാൻ പറഞ്ഞത്. ശരിയാണ് ഇദ്ദേഹം ചെയ്തതെന്നല്ല പറഞ്ഞത്, ബട്ട് ഇറ്റ്സ് നോട്ട് 100% to be blamed on the pediatrician side. മറ്റേ സൈഡും കൂടി പ്രശ്നമുണ്ട്.
എക്സ്പ്ലെയിൻ ചെയ്തിട്ടുണ്ടാവും. ഇപ്പൊ ഞാൻ ഒരു ഉദാഹരണം ഞാൻ പറയാം. ഒരു ഉദാഹരണം ഡോക്ടർ മൊയ്തീനെ എല്ലാവർക്കും അറിയാം. ഡോക്ടർ മൊയ്തീൻ ഹാസ് ബീൻ ഹിയർ ഇൻ ജനറൽ പ്രാക്ടീസ് ഫോർ സച്ച് എ ലോങ് ടൈം. ഇവിടുത്തെ ഏത് വലിയൊരു സൂപ്പർ സ്പെഷ്യലിസ്റ്റ് എഴുതിയാലും പലപ്പോഴും പേഷ്യന്റ് ഈ സാധനം കൊടുത്തിട്ട് മൊയ്തീൻ സാറിന്റെ അടുത്ത് എന്ന് ചോദിക്കും, ഇത് കഴിച്ചോട്ടെ എന്ന് ചോദിക്കും. സാറ് ഇത് കഴിക്കണം. സാറിന്റെ ഉത്തരം അത്രേ ഉള്ളൂ. സാറിന് എത്ര വലിയ കൊലകൊമ്പൻ സൂപ്പർ സ്പെഷ്യലിസ്റ്റ് എഴുതി കഴിഞ്ഞാലും സാറിന്റെ അടുത്ത് പോയി പലപ്പോഴും ചോദിക്കാറുണ്ട്. ആൾക്കാർ ചോദിക്കും വെദർ ദിസ് ക്യാൻ ബി ടേക്കൺ ഓർ നോട്ട്. സാറിന് സംശയമൊന്നുമില്ല. സാറിന് അവിടെ എഴുതിയിട്ടുണ്ടെങ്കിൽ കൊടുക്കാൻ പറയും. അപ്പോൾ എനിക്ക് ഒരു സാധനം എനിക്ക് അറിഞ്ഞൂടാ ഇങ്ങനെ ഒരു ഇത് വരുമ്പോ
ആ കാര്യം വർമാജി പറഞ്ഞ ആ പോയിന്റ് ശരിയാണ്. ഡെഫിനറ്റ്ലി ചെയ്യേണ്ടതായിരുന്നു എന്നുള്ള കാര്യം ഡെഫിനറ്റ്ലി ഐ അഗ്രി. ദാറ്റ്സ് റൈറ്റ്.
Thank you very much. Thank you, Hari, and thank you, Shiji. Thank you.
Okay, so we have come to an end to our monthly CME program. So I give the vote of thanks. So I thank both the speakers, Dr. Shiji Joseph and Dr. Harikrishnan, both from the Amala, and for the that all the pediatricians need to know. And thank you for your wonderful talk. And I also thank all the Amala team for the excellent work doing all these days for the girl child activities, and for particularly the Sunil sir and team. So thank Amala for that activities. And also regarding our last month was teaming with activities, we have Madam forgot to mention about the Youth Day celebrated by the special talk given by Newton sir last month. And the next month, and I also thank all the delegates who have joined here. We have almost 80 delegates at the time, and many in the YouTube also. So all the delegates, all the senior members, Purushottam sir, Parvati madam, and all the senior faculty of my college and from the Amala. And also we have plenty of academics coming up in this month. And then on the next Tuesday, we have a Cancer Day talk. Our own alumni, Dr. Badita is coming back on Tuesday, and we have a PG discussion on pediatric cardiology, and we have a talk on hemophilia by Sheila Madam on the last Tuesday. All of you joined today, and hope you join us on next occasion. And thank you from IAP Thrissur. Thank you for joining. Jai Hind and Jai, and good night. Thank you.